So as I was saying, COPD is a predominantly a disease as we age. So it is initially diagnosed by spirometry. Most of the time we would say clinically, a patient coming in may have COPD, but you have to do spirometry to diagnose it. There's two different grading systems on spirometry that will help diagnose COPD. The two large associations and consortiums basically use what is called the FEV1 FVC ratio. As for the GOLD criteria, which is the Global Obstructive Lung Disease Initiative, they require an FEV1 FVC less than 70%. The American Thoracic Society on spirometry recognizes anything less than the lower limit of normal for a patient based on their age, race, and height. And that tends to be somewhere less than 0.8% or less than 80% for these patients. So between 70 to 80% tends to be one of the gray areas of contention in terms of whether a patient should be diagnosed with COPD or not. Prevalence in the US is about 7% in all individuals, but you notice that as we age, our lung function declines as well. So prevalence tends to be higher, and it's about 10%. COPD in and of itself is actually a non-curable disease. We can symptomatically treat these patients, and there is actually a high mortality. You can see this graph, and this is actually older data from 2007 to 2009, where they have the prevalence based on gender and age. And you see above 65 up to greater than 85, there is a higher prevalence. And typically women tend to show more often with COPD than men. As per the American Lung Association, in 2018, they did have a survey which showed rates of COPD in each state. The lowest state ended up being Hawaii, which was 4%, and the highest was 15.3% in West Virginia. If you see the arrow, you can see in New York, the male percent prevalence is 5.2 and the female is 6.4. So we're running around the middle of the country, despite all our air pollution. Based on natural evolution and development of the lung actually continues growing and improving in terms of the FEV1% predicted up until our peak, which is somewhere around 20, 25 years old. And after that, it's all downhill from there. We basically have a decline in our FEV1% as we age. And you can see that it'll go down to around 60, 65% in the 80s and 90s. And as we said, usually the FEV1% predicted can, with the FVC percentage, will give you an indication of COPD or obstructive lung disease in these patients. So mortality has been slightly improving in terms of COPD from 1999 to 2014. It actually has gone down after 2014 to being the 4th overall leading cause of death in the US after heart disease, cancer, accidents, and unintentional injuries. Before, the COPD actually used to be 3rd leading cause, but accidents and unintentional injuries has increased. This is actually mostly due to like the opiate epidemic and things like that, where patients would end up accidentally overdosing and expiring. So we used to be, if you just look at disease related, then COPD still remains the 3rd overall leading cause of death. And most deaths occur in patients older than 65. And if you look at the age groups, anybody older than 85 actually has the highest death rates for COPD. So when we have any patients referred to our pulmonary clinic, we do want to talk about their history of symptoms. So they usually come in with dyspnea or chronic cough. We want to talk about how long this has been progressive over, what makes it worse, if it's all the time or only intermittently. Patients do tend to have recurrent lower respiratory tract infections, and occasionally, some of these patients who are non-smokers, you can see if you talk about family history, whether they have genetic or developmental abnormalities that are associated with lung disease, or patients who are actually from other countries that use a lot of biomass fuels in terms of cooking and heating, that has also become worldwide a large risk factor for development of COPD. So you want to assess these symptoms in our patients, and typically there are two different questionnaires that you can use. One is the Modified British Medical Research Council, the MMRC. This is actually one of the easier ones to do, and it goes from 0 to 4, as 0 being what we consider relatively normal. You only get breathless with strenuous exercise. Grade 4 is where these patients tend to be too breathless to even leave the house, or if they get breathless with just doing ADLs, washing, bathing, dressing. The other assessment that we can use is called the CAT, COPD assessment test. It's a questionnaire. There are 8 questions in the questionnaire, and scores go from 0 to 40. The higher the score is an indicator of worse disease. So they have similar questions of cough, phlegm production, tightness in chest, activities. They also include whether patients feel energized or if they sleep well. A lot of our patients have sleep complaints as well. So when we talk about categorizing these patients who are diagnosed with COPD, we have done spirometry on them, and they show that the FEV1 FVC is less than 70%. The gold classification 1, 2, 3, and 4 is based on, can determine the severity of the obstruction that you see. So here is the FEV1. You look at the FEV1, and if it's falls in either of these sections in terms of percent predicted, then you can classify the severity of your COPD or obstruction from mild to very severe. For us to determine treatment for these patients and group them in categories, we take both the severity of the obstruction on the spirometry as well as the assessment of how many exacerbations they've had over the past year, as well as any symptoms that they do have based on the MMRC and the CAT questionnaires. So this, for the GOLD guidelines in 2008 that came out, they basically is the kind of algorithm you would use for diagnosis of a COPD patient, as well as categorizing them to help with treatments for them. So you'd start with the spirometry, which would confirm your diagnosis. You would assess the airflow limitation severity, and then you would base the category, the groups A, B, C, or D based on how many exacerbations they had with the symptomatology that they had. So the mainstay of COPD, though, besides symptomatic treatment, is prevention and maintenance. So what does improve mortality in these patients is smoking cessation. It's the single most effective and cost-effective intervention. So they do recognize that quitting smoking is actually very difficult, and only actually less than a third of smokers become sustained quitters. So we have multiple different therapies for nicotine replacement products. Comes in oral, lozenges, there's also sprays, there's transdermals, and inhaled nicotine, as well as nasal sprays. But we do recommend that these with nicotine replacement therapies, that patients do get offered options such as variancycline and bupropion, which are helpful and showed improved sustained quitting. So they found that basically with these smoking cessations was the lung health study done in 2002. It showed that smoking intervention with treatment therapy versus smoking intervention without treatment versus no intervention showed that these patients reduced the decline in their function, FEV1 function in the middle-aged smokers. So this is part of the reason why we do promote smoking cessation for our COPD patients who do smoke. There's we use the 5 A's for smoking cessation intervention. You would ask all patients who come in who are identified as smokers every visit, and then you would also advise them to quit. You would assess whether they are willing to quit or desire to quit within the next 30 days. And then you would offer them quit plans, practical counseling, as well as the nicotine replacement therapies or the bupropion or Chantix. We do, for insurance purposes, to say that we have done smoking cessation counseling require scheduled follow-up contact, either telephone or face-to-face visit. So besides smoking cessation, other options to help decrease mortality in COPD patients is actually very important to have them vaccinated, which includes influenza vaccine every year is offered, and then the pneumococcal vaccine. So any patient greater than or equal to the age of 65 years should get the vaccine, and any younger patients less than 65 with significant comorbid conditions such as heart disease, diabetes, end-stage renal disease should be offered the pneumococcal vaccine. This decreases the prevalence of community-acquired pneumonias and decreases mortality as well. Previously, the Prevnar 13 was offered for about 1 to 2 years for any patient age greater than 65 years, but after review of retrospective study, it actually didn't show that it was that much of a benefit in reducing pneumonia, community-acquired pneumonias in the COPD patients or any geriatric patients. So if patients do want that, it's just a discussion whether they would benefit or not. So mainstay of therapies in terms of medical management, we do give inhaler therapy. And the treatment goal basically is to reduce their symptoms and manage the frequency and severity of exacerbations so that they can have improved quality of life. So treatment recommendations is that for all patients with respiratory symptoms and FEV1 between 60 and 80%, which is group 1 and 2, they get treatment therapy with inhaled bronchodilators. The addition of long-acting medications typically occurs with patients with FEV1 less than 60%, and multiple combination inhaled therapies are for patients who are symptomatic with COPD and FEV1 less than 60%. So we'll go over the different groups of the different inhalers. There are also a recommendation as adjunct that everybody gets pulmonary rehab if you are symptomatic. Also, if you are discharged after exacerbation from hospital, they do recommend referral to a pulmonary rehab center. And for any patient with COPD and resting hypoxemia, which is less than PaO2 of less than or equal to 55 millimeters of mercury, or a SAT of 88% on Romer, they should get oxygen therapy. So caveats with bronchodilator therapy. We do not, so there are multiple different categories of bronchodilators. If you do not respond to one, it doesn't mean you won't respond to the other one. So we do try all of the different bronchodilators on patients. Patients respond differently to each group. And in general, the long-term therapy response may vary day to day, also based on how compliant they are with their medications regularly. We do use short-acting and long-acting. And so every patient generally should have a short-acting bronchodilator for as-needed use. And if needed, maintenance therapy to control symptoms and allow for exercise. So beta agonists, the benefits of these is that they inhibit, they reduce the rate of COPD exacerbation by about 15 to 20%. The mechanism of action is that they inhibit airway smooth muscle cell proliferation and inflammatory mediator release. And they're also effective in stimulation of mucociliary transport and clearance of mucus production and phlegm. So side effects we typically see with these are tremor, reflex tachycardia, hypokalemia. These tend to be dose related as well. More often, if patients continuously use them, you'll get increasing side effects. I think there's a raised hand. Yes, no?
I have a question, but are you almost done, Dr. Chow? I can wait to the end.
I mean, you can ask now if it was anything we covered.
Well, I mean, you started off your presentation sort of saying that COPD is associated with aging, and I've never ever heard that. My understanding is that it is really associated with like almost 85 to 90%. It's associated with cigarette smoke or environmental issues in terms of exposures to toxin, whether work related or et cetera. So I was just a little confused. And I also wanted to know if you had any information about social determinants, because we often see COPD being associated with poor folks who are living in poorer conditions in terms of environmental justice. So do you have any epi in terms of like who's affected and that kind of information in terms of population?
So in terms of that, yes, the CDC does have data on whether lower socioeconomic groups have a higher rate of COPD, which they do. It's also gender related as well. As you saw, predominantly in all age groups, women have higher rates of COPD. When we look about the actual, if you look at all of COPD, it is actually an underreported disease that is actually most frequently underreported in the elderly. And based on physiology and natural progression of lung function, everybody normally, as you age past 25 to 30, has a steady rate of decline in lung function. So if you look at the group of COPD, it is not actually smokers who is the predominant. If you look at smokers as a group itself, like yes, they have a higher rate of COPD than non-smokers. But in terms of the group of COPD, it's not predominantly just smokers. You are correct in saying that biomass fuel has actually become a very large reason why people have COPD.
I'm sorry, what did you say? What?
The biomass fuels and environmentals in the world, that is actually becoming a very prevalent reason of why people are developing COPD rather than smoking itself.
I believe you, Dr. Chow. I don't, it doesn't really quite make sense. And then moreover, to say that it is aging related is also discounts the fact that the baby boomers, if this is sort of like the group that we're talking about, they were the one generational cohort that has had the highest level of smoking of any generation, like before and after. And so I wonder, to sort of say that it is age related is not also taking into consideration sort of what was going on with that particular cohort, who is who's getting it, their exposures, and you know, I mean, to me, I always feel that COPD is really about social determinants of health and about people not being able to living in poorer conditions, being exposed to toxins, not being able to get into care or be linked to care. My primary population are people with HIV, which also have a higher level of smoking than people without HIV. And so, of course, we also have a lot of COPD and so forth. So I'm not convinced. I've never seen anything saying that COPD is aging related.
Well,
I mean, as we get older, yes, our lung function declines, but not everyone gets COPD.
no, that is true. But when you look at each age group itself, and I don't know, maybe it's just how I define age related versus how you define age related, as you go up across the board in any year, basically, as the age group, like, so I'm showing this from prior studies in 2017, clinics of geriatric medicine. Basically, each group has a higher prevalence of COPD.
Right, but this is also generational. Like the boomers are basically, the 65 to 74, 74 to 80, 75 to 85. That's a generational cohort, the boomers and the vets, mostly the boomers there. And so it's not so much that sort of the burden is going up. It's just the boomers, the boomers already had a high level of risk exposure. And then when you add on like poverty, race, and ethnicity, it's muted here in terms of exactly who is getting it and why.
I'm not disagreeing that with socioeconomic status, the lower socioeconomic status have higher risk factors for COPD. They tend to be the more predominant number of COPDs in that age group. So yes, there are those factors in age and race, and when we do spirometry, have to account for race as well, for what we consider normals for what they actually use in the spirometry. That's why we always use the percentage based on a race as well as age and height for their spirometry to find out what's normal and abnormal.
Right, and also sort of underlying conditions, right? If they grow up with asthma, which is, if you grow up poor and Black, like your chances of having asthma as a child. So if you have these pre-existing kind of fragile pulmonary systems, like it's only sort of adding to the risk.
Yes, it does add to the risk. And there are different risk factors that make the likelihood of developing COPD later on or being diagnosed with COPD during their lifetime higher. That is correct.
Yeah. Okay, thank you.
And we do have another question, I believe, from a student, Amotunde Sikuda. Please feel free to unmute yourself and speak up. We have you. We do see the hand risen. If you do have a question, just post it in the chat, and we'll address it later, I suppose. Thank you. There is another hand, Daniela.
Yeah, no, that was by mistake. Sorry.
Daniela, I'm not sure if we hear you. Hello?
No, I said it was by mistake. I clicked.
Oh, sorry. Never mind. Okay.
No. So I think we were talking about the different beta agonists and antimuscarinics, which are the different types besides the inhaled corticosteroids for therapy in COPD patients. Both of these do help improve lung function as well as decrease rates of exacerbation. They have different side effects. Antimuscarinics tend to have more of issues with like the anticholinergic side effects, such as dry mouth and occasional urinary symptoms. So these medications, short-acting bronchodilators, are generally recommended for our group A patients, which are the ones that have low to none symptoms and low risk of exacerbations. That was the lower left-hand corner of the grid, and would be offered either beta-2 agonists or anticholinergics. When you compare the beta-2 agonists versus the anticholinergics. The anticholinergic ipratropium alone showed a small benefit over albuterol in terms of lung function health status. But this is also dependent on the patient, whichever one they do feel is more useful to them. And patients do usually have a preference. So combination short-acting bronchodilators such as Convivent, Duonebs, they can be also beneficial for patients who don't feel as much of a symptomatic relief from use of just one. Since they do work in two different types of mechanisms of action, they can result in more bronchodilation than a single agent, but it does not improve or decrease the rate of exacerbations that patients have if you use a combination versus just a single short-acting. So for group B, we tend to recommend a longer acting bronchodilator. And so these are the more symptomatic patients. They don't really have exacerbations requiring hospital stay, but like daily livings, if you do the MMRC or the CAT questionnaires, they'll have a higher scoring for that. So you can either do long-acting beta agonist or long-acting antimuscarinic. Generally, we do prefer the long-acting antimuscarinic over the LABAs. So they showed that with TIOTROPIUM, which is long-acting antimuscarinic, that versus the LABA, that they do have an increased time to first exacerbation, and it was more effective in reducing exacerbations, but no significant difference in hospitalization and mortality for these patients. So these are the different LABAs on market right now. Generally, if we had asthmatic patients, we would stay away from these, but COPD, they do not carry the same black box warning of cardiac disease and heart attacks. So they are able to be offered to these patients with COPD. So now with the LABAs, the largest trial of was with salmeterol, is a TORCH trial, and with these patients, they had about 6,000 with mostly severe COPD. FEV1 was around 44%. And they compared salmeterol versus fluticasone, which is an inhaled steroid, versus the combination and placebo. They showed that salmeterol did significantly decrease exacerbation, improved lung function, and improved health-related quality of life. It was not significantly different in mortality, but it did have a trend in decrease. Is there Andre Emmanuel has a question?
Dr. Chow, can you please go to the previous slide for 1 second? Yeah, this one.
Mm-hmm.
Okay. All right, thanks.
Okay. So these are just the trials that allowed the approval of the different LABA. So indacterol showed that it versus placebo that that basically it did help with the FEV1. So okay. So the LAMAs, which the oldest LAMA that we have is tiotropium. In the UPLIFT trial, it was a randomized double-blind trial, 4 years and over 4 years, and as about 6,000 patients, and they compared tiotropium versus placebo. It did show that there was mean absolute improvements in FEV1 were significant compared to placebo. And it did, but it did not reduce the rate of decline of FEV1. So as I was saying before, in general, long-term, there really isn't anything that affects FEV1 or decline in lung function. So tiotropium did a few years ago came out with a Respimat formula of inhaler. So it used to be provided as a dry powder inhaler, and now they had the Respimat, which is a soft mist inhaler. There was a question of whether patients using the Respimat formulation of the tiotropium caused increased cardiac events. So they did a TIOSPHERE trial. This was in 2013, and basically showed that there was no difference in risk of mortality. They did only have a mean follow-up of 2.3 years, and they excluded severe cardiac disease. They didn't show a difference in arrhythmias or intervention or need to go hospitalization, whether you use the hand inhaler versus the Respimat. So these are the different, these are two other LAMAs that have been put on the market. Tudorza, I would actually note, is a breath actuated inhaler. So can be useful for those patients who cannot coordinate for dry powders or MDIs. So in, we had covered group A and we were talking about group B. So in group B, if patients who have symptoms are not well controlled with a single long-acting bronchodilator, you can do an additional. So basically now we've offered patients a combination of the LAMAs and try to avoid the potential side effects of adding in inhaled corticosteroid for these patients. They showed that there was minimal improvement in quality of life, small increase in post-bronchodilator FEV1, but there's no real data comparing basically the LAMA-LABA versus a LABA-ICS yet. So these are the current LAMA-LABAs on market right now. So they do have a Respimat inhaler as well as a Nora, which is a dry powder inhaler. Adjunctive therapy, which isn't used very often, and I don't recommend unless you actually are pulmonology to offer these patients, is THEOPHYLLINE. It's basically a non-selective phosphodiesterase inhibitor, and it's considered a respiratory stimulant. It improves diaphragm contractility. So there is a narrow therapeutic range, so they tend to have to require frequent level checks. And it's used in basically patients with severe disease without any symptom control. So group C, which is where they have frequent exacerbations and less symptoms, initial therapy with the LAMA helps reduce their exacerbation rates. And then if they do continue to have further exacerbations, you would start them on combination therapy with either LAMA-LABA or ICS and LABA. Okay, so when we talk about inhaled corticosteroid therapy, it's typically in combination with another drug for COPD. It modestly slows progression of the respiratory symptoms, and usually it's the COPDs characterized with airway and systemic inflammation. So these are more typically beneficial for patients who are like the chronic bronchitis, who phlegm production, a lot of inflammation going on. So they show little impact in terms of mortality benefit and shouldn't really be used as a monotherapy for patients with COPD. So adverse effects with inhaled corticosteroids, and it tends to be a lot of issues with geriatric patients in terms of that they do have a slight increased risk of development of pneumonia. They can have issues with cataract development over long term and decreased bone density. We also do have more frequently, the issue is that some of these patients, without rinsing out their mouth, do have development of oral thrush. So I'm not going to cover the TORCH trial. Basically, they were showing there was a combination of LABA and ICS had some improvement in all-cause mortality compared to placebo. So that's why we do use ICS in patients with COPD. This is also, so this is where we found the INSPIRE trial basically showed us that where it does improve mortality and exacerbation with use of a steroid, it did show that there was a risk of pneumonia with more frequently in the ICS group, and hazard ratio for time to first pneumonia was 1.94. So these are our current combination therapies of ICS LAVAs on market. Advair and Symbicort have actually gone generic. So they do have generic options right now. So the question recently has been whether you want to treat with LAMA LAVA versus LAVA ICS. So there was a comparison of indactyl and glycopyrronium. So glycopyrronium isn't actually offered in the US right now, but they were using this as a model for the LAMA LAVA, and it's a comparison against the LAVA ICS, and they found that LAMA LAVA reduced the rate of mild severe COPD exacerbation by 11% compared with just ICS and LAVA. And they had fewer rates of pneumonia, which is 3.2% in the LAMA LAVA versus 4.8% in the ICS LAVA combination for these COPD patients. So group D, we tend to do, these are high exacerbations and also high symptoms, high scores on the CAT and the MMRC. So they will be started on triple inhaler therapy. And this has been shown to decrease the risk of mortality, exacerbations, and hospitalizations, and improve health quality of life. So adjunctively, we were talking about THEOPHYLLINE previously. We also do now offer Daliresp or roflumilast, which is a PDE4 inhibitor. So this has a better safety profile than THEOPHYLLINE, and we offer these to patients with history of exacerbations, at least 2 per year or 1 hospitalization with chronic bronchitis. So these tends to be the patients with a lot of mucus production, phlegm production. It is started at medication titration to reduce the rate of discontinuation because they tend to have a lot of GI side effects from this. And then there's always been a question about prophylactic antibiotics. So chronic antibiotic therapy generally is not indicated in stable COPD. It's used in refractory COPD with frequent exacerbations and bronchitis as well. They found that when they use an macrolide, or the antibiotic group significantly fewer exacerbations than placebo. So the recommendation is you can use either erythromycin 250 milligrams twice a day versus azithromycin 250 milligrams daily. We do tend to use erythromycin more because erythromycin is associated with increased incidence of bacterial resistance. Okay, and the benefits of antibiotics in these patients, we usually would stop treatment if they were using it for about 48 to 52 weeks. That is a relatively long time, which should be considered to stop antibiotic prophylaxis in these patients. Alpha-1 antitrypsin deficiency is also a reason for COPD development, and that we do generally have to do replacement therapy if they are diagnosed with alpha-1 antitrypsin. These tend to be more frequently diagnosed COPD patients at a younger age. So they would get weekly infusions, and we would target their serum levels above 11 millimoles. Okay. And adjunctively for symptom treatments, mucolytic agents. Mucus impacting those chronic bronchitis patients with COPD can contribute to worsening of their symptoms. We have used acetylcysteine. It thins these secretions, but it has no effect on the spirometry, and it can cause bronchoconstriction, so you must give it with a bronchodilator. We usually typically give like the albuterol or ipratropium prior to giving the mucomycin acetylcysteine. Okay. The biggest issue in terms of treatment for geriatric and actually all patients is the poor technique that they have in terms of using any of the inhalers that we prescribe. They tend to have, now have a lot of different mechanisms or inhaler delivery systems. And for our elder patients, as well as our severe COPD patients, some of them cannot produce the necessary inspiratory force to effectively pull in the medication and deliver to the lung itself. So for those patients, they have developed the RESPMAT, which is a soft mist inhaler, as well as use of a nebulization medication can be more beneficial in terms of medication delivery for these people. And we do recommend that all patients with symptoms get pulmonary rehab. Basically, in Brooklyn, there's only one pulmonary rehab center that is New York Presbyterian Methodist over there. They have a pulmonary rehab that we refer to. Otherwise, the only other pulmonary rehab centers are within Manhattan. It does help improve the quality of life for these patients, both whether they do an inpatient or outpatient program, and can reduce hospitalizations after discharge or readmissions. They are effective over a period of time, but can benefits of doing pulmonary rehab slowly decline over time. So we do try and get them back in every 2 years to redo pulmonary rehab. So they do conditioning with lower extremity exercise. Most frequent is lower extremity exercise, which is walking on a treadmill or a track, or stair climbing exercises. For those who cannot do lower extremity exercises, there are options of upper extremity exercise, which are repetitive arm motions, or they can do an arm crank bicycle with resistance. They can also use light weights like 1 to 2 pounds. Occasionally we do say that you can just hold water bottles that may benefit the movement and exercise that they have. And they must do continuous exercise for 20 minutes. Interval training is acceptable as an alternative, but we do recommend that they at least try to maintain exercise for 20 minutes. And breathing retraining. So basically they, for COPD patients, pursed lip breathing can help create slight amount of PEEP in these patients to help them in terms of feeling less dyspneic. It can increase their tidal volume. So what they do occasionally do is offer breathing through mouthpiece and resistance, kind of like breathing through the straw analogy. It's not usually often, it's not a routine element, but it can, for certain patients, help be an effective response. And so measuring their activity after, before and after the rehabilitation program, we generally do a 6-minute walk test to determine the total distance they can walk and their oxygen saturation while walking. Anything greater than 35 meters improvement is generally considered significant for these patients. And periodically, yearly, by 1 year to every 2 years, you would do a 6-minute walk test on patients just to monitor their physical activity. Okay. And so patient support, education, education in terms of their medication regimen, as well as inhaler techniques and how to use inhalers, improve the compliance, as well as their daily symptoms for these patients. And as I said before, we would recommend smoking cessation and increased nutrition. As patients get COPD get more severe, they do tend to use more calories, and weight loss in severe COPD patients can be detrimental to their actual breathing and cause more dyspnea as their respiratory muscles work harder. So COPD in any group of patients is also associated frequently with depression, as well as decreased sexual anxiety, activity, anxiety, and fatigue. Okay, so these are all issues that need to be addressed in these patients. So the recommendations, I think I just want to cover one thing with the oxygen therapy for COPD patients, because a lot for the severe COPDs who are hypoxemic, it does actually improve mortality for them. And this will probably be the last thing I will cover. So the long-term oxygen therapy showed that there was improved mortality, and use of oxygen therapy greater than 15 hours a day did correlate with this. It reduced secondary polycythemia, improved exercise, and improved quality of life. So these are the CMS covered insurance acceptable indications for oxygen therapies in severe hypoxia at rest for these patients. So you either need an ABG, which shows an arterial PO2 of less than or equal to 55, or a room air saturation at rest of less than or equal to 88%. For those patients with pulmonary, they have a higher oxygen saturation at less than or equal to 89%, and a PaO2 of less than or equal to 59 millimeters of mercury, and polycythemia. And these patients will also qualify for oxygen therapy. The LOT trial was done recently, and this is the because frequently oxygen therapy is given to COPD patients without severe hypoxia at rest. So this study was done to see if patients with COPD benefited if they had mild, moderate hypoxia, which is 89 to 93% at rest, but had induction of hypoxia with exercise. And so they were randomly assigned to 2 liters per minute, continuous or none. And so that is one group. And then the second group was 2 liters per minute during exercise and sleep, or none. And so they were monitored for anywhere from 1 to 6 years, and they showed no difference in time to death or first hospitalization, rate of exacerbations, or COPD related hospitalizations. So it did not benefit these patients with mild, moderate hypoxia to get long-term oxygen therapy. Okay, and I think that is about 5 minutes if anybody wants to have questions further.